I'll just wait another minute till people are seated. Yep, okay, let's go for it. Right, hello everyone. We're here today to talk about developing analytics for better pharmacy stock control. I'm Hazel Kirkland, I'm a pharmacist at Nottinghamshire Healthcare NHS Foundation Trust. So our trust is predominantly mental health services to mental health, learning disabilities, forensic, and we do have some community services, so we're a non-acute trust. Okay, just to outline what we're going through today, I'm going to start with some background about pharmacy stock control. Woo! Exciting. And then the inventory management process, and then Martin's going to do the technical stuff, talk about the project methods, including forecasting methods, inventory management model, simulating the performance of analytical tool, results, and then finally a summary. So, why are we talking about pharmacy stock control? As from the woos, it's not really a topic which most people in pharmacy find very exciting. But it was important for Carter to include on his 2016 review paper into efficiency savings within NHS hospitals. So Carter's recommendation was for a maximum of 15-day stock holding and maximum of 4 deliveries a day. So what is pharmacy inventory management or stock control? Oh, hang on. I've jumped there to my other slide. Oh yeah, sorry. Right, I'll start again. Okay, so what is pharmacy inventory management? Oh, I think I've lost a slide somewhere along the way. Okay. So pharmacy inventory management is costly, it's labour intensive. So if we reduce pharmacy stock holding, then it provides a one-off cash release. But if we improve the efficiency of the process, then it saves staff time, which is recurrent savings. But above all, we need to get it right. We need to get the medication to the patients when they actually need it, and that's essential for patient safety. And yet, despite this, there's been no change in the tools available for pharmacy procurement staff, even though there have been advances in forecasting, which other industries, for example, retail, have already adopted. So this is an area where analytics can potentially help. The project started out from a dissertation that I did for my master's in health informatics, which Martin was my supervisor for. And then, thanks to the Health Foundation, we received funding from the Advancing Applied Analytics programme, and from that we're able to develop an analytical tool. Oh yeah, there it was. Right, so pharmacy inventory management, what is it? It covers ordering, receiving and invoicing. So the process starts from creating reorder levels and reorder quantities for each individual drug product. So within our trust at the time of the project, we had to input these manually for approximately 1,200 drugs. Now, if you're in an acute trust, then there's an awful lot. They have a much wider range of drugs that they stock. So a product comes up for order when the stock level drops below the reorder level. And at that point, the order is then sent to the wholesalers, and we get a delivery, so the lead times can range from same day to multiple days. Staff receive the order and then check it against the paperwork, input it into the computer system, and then the goods are put on the shelf and the invoice is paid. Simples. Well, maybe not. So this box is deliberately small, but it shows the process map just for one part of that, which is for receiving goods. And it demonstrates that there is a huge amount of complexity to just that one part of the process, which makes it time consuming. So when we consider what we consider when we're ordering, if other industries are already using analytics for their inventory management systems, then why don't we use the same methods that they do? Well, there's fundamental differences. When we consider how much stock to keep, there's a balance between the costs of the stock on the shelves, staff time to process the orders and to follow up any stock outs, and storage capacity. However, within healthcare, we also need to factor in the clinical risk to patients if they don't receive their treatment on time. Within retail, if you have a stock out, you might lose a few customers. Within pharmacy, you might cause severe damage to a patient's health. But there's also a difference in demand profiles within hospital pharmacy. So we have to stock critical drugs, some of which are used very infrequently, and some which just expire, but you have to keep them anyway. Within retail, if you have a product that doesn't sell, you just don't stock it. So the brief for our project was to develop an analytical tool which works for different drug demand profiles, so high volume drugs or low volume drugs, which are very intermittently used, and everything in between, which is quite a big ask. It needs to be scalable, so whilst we test it on a small sample of drugs, in reality it's got to work across thousands of products. And it needs to be an end-to-end pipeline that can be implemented in practice and not just some theoretical concept. So we did build a pipeline, and we ran it in a shadow mode with an early version of our analytical tool, but then, as all these things go, the Trust decided to change their pharmacy stock control system. So while the analytical tool is designed to be system agnostic, the pipeline has a data manipulation layer which is bespoke for whichever particular stock control system you have. And now I'm going to hand over to Martin to take you through the methods and the results.
Thank you, Hazel. So, as with most work that people here are doing in analytics or operational research, we have some information and we're trying to make the best use of that information to help the organisations we're working with deliver on their aspirations. Right? And that's that role for analytics. So in this context, we've got information on the dispensing history from dispensaries and material coming out of stores. We've got knowledge around stock levels at a point of decision. At that point of decision, we also know whether there are any outstanding orders. I'm trundling along in one of Hazel's vans. And we have knowledge around the delivery lead times that we've experienced in the past. And the aspirations, as Hazel said, we want something that scales well across, to be applied to a large number of drugs with a wide range of characteristics in terms of volumes, criticality. Ideally, we want to reduce stock holding if that's possible, but the important tolerances are what we consider as an organisation to be the tolerable level of stock out. Now, that might be drug dependent. Also, we've got a preferred interval to the next order. So some of the approaches and the current approach is slightly reactive. So the systems run every day. If I look in my cupboard every day, if my number of cans of chickpeas have dropped below my reorder level, I rush to the shops and buy some more chickpeas, right? And then the next day I look and I'm short on carrots. I go to the shops and buy carrots, right? It's quite reactive. And given the complexity of the workflows that Hazel and colleagues go through every time there's receiving a delivery, we wanted to see whether you could impose a sort of order schedule rather than having that sort of reacting to the data. And also, our inventory model took into account whether you had storage constraints. We didn't use those constraints in the work that I'm talking about. So the two pieces of analytics is to forecast demand, and then based on the information you have and that forecast of demand, to make a decision about how many of a particular drug to order up the chain. So the analytics, well, so the forecasting, this was based on around 4 years worth of data. So we got some experts in from Birmingham Management School to help us with this. It's not really my area. We were interested, often in forecasting, you want the best guess as to what your quantity is going to be or what your demand is going to be. In this context, particularly with our focus on wanting to avoid stockouts, we're very interested in the upper tails of the distributions for demand. So we wanted to know our 50th centile, so our sort of best guess of what aggregate demand would be over a particular time period. But we're also interested in those upper centiles, and for storage constraints, we might be interested in those lower centiles as well. So we're interested in the whole distribution of total demand. And then, because we have uncertain delivery times, we're interested in that distribution of aggregate demand over a substantial, several periods, several different periods. And if we think I'm making an order today, that order has to be sufficient to last me until my next order is delivered. Okay? So I've got my interval to the next order, and then I have to wait for that order to turn up if I've got my decision today wrong, if I'm under. So we explored a range of forecasting methods. You'll be familiar with some of these, possibly. The TSB was explored given the rates of intermittency in this data. As Hazel said, if we look at time series of these data, for many of these drugs, you've got a lot of zeros on those time series, which makes the forecasting intrinsically difficult. And so we looked at specialist methods that have been developed for intermittent time series. And then we looked at this time hierarchical forecasting methods. And they seem particularly well suited to our problem, particularly because our daily demand isn't independent for each day over these series, given the nature of the problem. And so some of these approaches that parcel up time in different ways and then see how those forecasts perform did very well, and it did well, and it was selective for further use based on consistently good performance, and particularly at those upper centiles. So the inventory model, just a nice little 1950s style heuristic, kind of to find the lowest order that gives you a probability of above some level of your order being sufficient for the delivery of your next order. And there's some complex stuff if we bring in the storage constraints, but we didn't. So having built these, having selected a forecasting technique and built this inventory model, we, as well, Hazel built a simulation workflow to sort of test this out. And so that was taking, again, a time series of dispensing data and then using that to forecast demand, and then using that forecasted demand with the stock level and your knowledge about uncertain times in the inventory to give you an order quantity. And then that time series of demand just continues, and you simulate what's happening to your stock level as that stock leaves, and then you made an order, you sample your lead time for the delivery of that order, add it into the inventory when it turns up, and continue. Again, you're faced with exactly the same decision, but with a different set of information, and you sample again, and so on. Okay? How am I doing for time? All good? So we evaluating the performance. So for essentially the output of a simulation is essentially a time series of your stock level for that particular drug. We can count the number of stock outs, so we count the number of times the amount of drug falls to zero. And we can count the number of orders that we've made from the simulation. We know how many orders we've made. And then you can calculate the sort of time average of that stock level. So those are the metrics that we were using to evaluate the analytical tool. And then we can compare something odd's happened there. So we can compare, there's supposed to be one line in blue, and that is the simulated stock level for the proposed analytical approach. And then because we've used the real history of demand data, we can compare that to the performance achieved using the system in use at that time, which is, as Hazel said, was a sort of rock and roll based system that then had some additional input from the staff. And so we compare those metrics across. Now, we had data on demand for 3 dispensaries, and then they order up to our stores. So when we were simulating this, we simulated using 18 months worth of dispensing data and forecasting and generating, using the simulation, generating the orders that go up to the stores. And then ran the simulation in the stores for 7 months, and then the evaluation is just over the last 6 months of that entire period. So we've got this sort of hierarchical structure in our supply chain. Our forecasters were telling us, well, you should just use, at stores, you should use all the information that the organization knows, but we wanted to reflect the reality that someone in the organization, knowing something doesn't always help. So our approach was based on the information that people would have in front of at the point of that decision. So there was an additional metric across a set of drugs. So we counted the number of times I go to the shops for chickpeas, count the number of times I go to the shops for carrots, but then across those 2 items, you can count the number of times that you're going to the shops. Which we'd expected would reduce under the approach we'd use because we're trying to impose an order schedule rather than have this kind of reactive approach. So I realize now that I should have wrote, there are all sorts of caveats around these results. And so I'm thinking for a room full of analysts, I really should have used a smaller font. For this slide at least, right? But, so these are sort of indicative. So using the analytical tool that we've approached, developed, the simulation results indicate that we'd have a good reduction in the number of stock outs. We'd also have a good reduction in total stock levels, small increase in number of individual orders, but then big reductions in those internal deliveries from stores to the dispensaries and from external deliveries to stores. Results vary by drug, so that's another caveat, is we've looked at 16 drugs of the 1,000 or so. Maybe we looked at the 16 drugs where this might help. I don't think so, but it's worth stating. But we see that we've got some, a clutch of drugs at the top there, where we're reducing the stock level with no detriment in terms of stock outs. And then the rest is a bit of a trade-off. But then we get some wins overall. Okay, so just moving on to our conclusions. So Hazel and Chris Bealey sort of implemented and ran an analytical tool, taking data out of our inventory system, running it through the analysis, and coming up with suggestions for orders, established that that's feasible, which is great. Forecasting demand for in-hospital pharmacy is difficult for some of the reasons that Hazel alluded to. Our simulation suggests that you can impose a fixed ordering schedule with no detriment to your key metrics of stock outs and stock levels. There are advantages. Oops. Read the rest. So, okay. So there are reductions to be had in terms of these number of deliveries, which obviously has carbon savings on offer as well. And one thing I would say is I don't think this is the final word in the forecasting or the inventory model. I think these results are more indicative, they kind of more validate Hazel's instincts that this was an area ripe for analytics rather than we've done the best analytics possible, right? But I think that's allowed too, right? So I think it's really good. So there's still some problems out there where a bit of analysis can have quite an impact. Okay, so, and yes, more to do, more to learn, and get in touch. Ah, there was a final slide, wasn't there? Yeah, anyway, we can exchange contact details. Okay.
Thank you very much. We've got a number of questions on the slide, but there are a couple in there around real-world impact. So just make sure I'm interpreting the slides correctly, trying to pull those questions together. So this is a project which has got as far as the simulation stage rather than implementation as yet. Is that right? And are there next steps in order to get this into really, or have you taken some heuristics from it or something which have actually made an impact?
So, not impactful yet. First half of the project, developed the pipeline, ran in shadow mode, an early version of the analytical tool, and then that pipeline became, we'd have needed to build a new pipeline, and as people may know, that depends on quite a scarce skill, actually, and we lost access to that resource. And so the second half of the project was being simulating the impact. Yeah. Yeah, don't.
Thank you. Want to run through some of the questions?
Can I just say to that so we would love to develop this further. So there's two things to that. One is if anybody knows of any pots of money that would help, that'd be fab. And if anybody's interested in working with us, collaborating, particularly from an acute trust, because they've got maybe different set of drugs, different set of problems, then get in touch.
Can everybody hear me? Demand/supply models often see lower impact of interventions than expected due to supply-led demand, e.g. demand increasing as a system because more efficient or stock becomes abundant. Do you see this in your dispensary model?
So I'm guessing they're saying that fundamentally there are changes over time. Yeah, definitely. I mean, within our data, we've got seasonality, because obviously there's drugs which, like drugs for flu, which you only really get in flu season, and some drugs kind of go out of use when newer drugs come. So yes, there is variation, and actually during our time we saw some of that variation within the testing period that we used. Our forecasting, I think, is really designed to take that into account.
Yeah, I think the only thing I'd add, I don't think we'd necessarily expect to see supply-induced demand in this context, because this is kind of, the clinicians don't get to see how much stuff's in stock. So they just assume they can't. So I think this is more kind of, I don't think this would change behaviours on prescribing because of how the stuff is being done. I think it's kind of robust to those sorts.
Did you have to allow for shortages of certain drugs or products and provide alternatives predictively? Notice some of the drugs have been short in certain sizes, but smaller sizes can be doubled up to make the same prescription.
Yeah, so this was something that we hadn't actually taken into account because trying to set this up initially, we wanted to test whether something worked for without those extra problems, fundamentally. And so I think we've got to that stage where maybe we've got something which we think works that we can then look at if there are stock shortages. So in that respect, it wasn't a real world scenario. But yes, we didn't want to make anything too complex to start with what we were looking at.
Some of these substitution problems, I think it's fair to say that the substitution isn't built into the current systems already. And even at the level of pack size, you end up sort of unboxing and then reboxing things, there is a downside to that. But I imagine where you've got substitution between products, you can tweak your tolerance to stock out and sort of take a bigger risk on your 26 pack of something because you know it comes in a 52.
Does the model include more than one dispensary with the ability to pool inventory to support out of stock risk?
So yes, so there were 3 dispensaries and the stores. What we didn't do, because we wanted to test the model to know what it's absolute, whether it produced stockouts or not, we didn't include anything where we could move the stock around because we wanted to know whether the model worked and produced stockouts. So we do know that some of the stockouts that were produced could have been overcome by taking inventory from elsewhere, but we didn't want that to bias our results at all and to rely on that because we want a system that kind of works without having to do that.
Yeah, I guess those sort of workarounds are not ideal, and so maybe you shouldn't design them into because they're not all co-located, right?
Yeah, so some of them are geographically.
Just say if people want to go off to other streams, as I said before, more for you. But if you want to do that, then go ahead. We'll take another couple of questions while that's happening.
How does the model deal when a new drug is rolled out, for example, Ozempic?
Anti-obesity.
Oh, right. So again, that's not what we haven't looked at that yet, and I do appreciate that is one of the limitations of a system, in that you have to obviously wait for a certain amount of historical data before you can forecast accurately, and so what the amount of data you would need is something that we would need to look at kind of further, and bearing in mind kind of the thief may potentially need a longer range of data, but as I say, we haven't actually looked at that. So there are quite a lot of extra practical issues that in future, if we developed this, we would need to kind of include. But for the moment, we were trying to get the fundamentals right and then add in the idiosyncrasies on top of that later.
For a new drug, you wouldn't rely on historical data, right? You take a guess and buy some.
What did you use to create your simulation?
It was done from scratch based on four loops. Yeah. So we didn't use any particular packages within any specific simulation packages. We just kind of wrote the whole process down to run through.
Can you track where individual clinicians or teams might have a personal preference and when that contradicts, for example, NICE guidelines?
I think that's something you wouldn't necessarily use this system for. So what we're trying to do is we're trying to look at what we would want to order if you were looking at the clinical application and the clinical prescribing and practice of a particular unit or clinician, then you would look at the data in a different kind of way.